All right. Well, good afternoon, everyone, and good day, everyone, and welcome to Paediatric Teaching today. I wanted to talk about something, not about a particular disease, but how to do neurological assessment of children, because I think it's something that we often don't practice so much, and it's something that you need to understand the theoretical basis for it to be able to do it well. So I'm going to talk about the neurological examination or neurological assessment of children. I'm not going to talk about CT scans or MRI scans, as I think most of the diagnoses that we see can be made without those things, just with a proper examination and a history. And even if you are going to do a CT scan later on, it's really important that you've actually done a proper examination first, a proper assessment first. So for some people, they might say that the neurological examination of children is the same as for adults. Well, in some ways it is, because we assess the child's conscious state, and in doing so, in communicating their conscious state, you might just describe their conscious state, or you might do a Glasgow Coma score or the AVPU score, alert, verbal, pain, unresponsive, and that depends on the circumstances. And then you might assess their central and peripheral nervous system, their tone and their power and their coordination and their reflexes and their sensation, and then their cranial nerves. So in some ways, the neurological examination of children is the same as what we do for adults, but it's actually different. And it's different because it's a bit more tailored to the presenting problem and the symptom the child has. And it's more opportunistic. You don't have to go through everything in exactly the same order. And when you're examining children, it should be, you start the neurological examination even when you're talking to them, even before you start touching them, because it's an observation of their function, their activity, their behavior, their movement, their interactions. And so you can actually do a lot of the neurological examination just by talking to the child, talking to the parent, interacting with the child. Much of your neurological examination is those aspects, the observation of their function, their activity, their behavior, their movement, their interaction with their parents, their interaction with strangers, their interaction with you. And the neurological examination is integrated with the general examination. As I said, during your general examination, you can identify many neurological features, and also there are many general systemic problems that can cause neurological problems in children. So, for example, hypokalemia from diarrhea can lead to weakness. And sometimes children present just weak or floppiness, and you have to work out why. And sometimes it's not a neurological disease, it's a general disease. And the last reason why the neurological examination is different in children to adults is because it takes into account age and their developmental stage. So you have to have some understanding of the child's developmental stage at a particular age. So for all those reasons, the examination is a little bit different in children than it is in adults. And the simple way to do a neurological assessment in children is to ask two questions. And the question should be asked, I think, in this order. And the first question is, where is the problem? You should always ask, where is the problem? Because you need to know whether the problem is a central problem or a peripheral problem. Is it unilateral or bilateral, right? And these are fundamental questions. If you ask them at the start, then you can work out if it's a central problem or a peripheral neurological problem. If it's a central problem, it might be in the cerebral cortex, or it might be in the cerebellum, or it might be in the brainstem. If it's a peripheral problem, it could be in a number of different levels: the spinal cord, the anterior horn cells, which are part of the spinal cord, the peripheral nerve, the neuromuscular junction, or the muscle. And there are clinical features that can tell you which level the problem is. And then, is it unilateral or bilateral? Because if it's unilateral, if it's unilateral, it tells you something different to if it's bilateral, especially when it's a central problem. So these are just fundamental questions you should ask yourself as you're considering a child who's got a neurological problem. It's only after that, after you try to work out where is the problem, then you should address the question of what is the problem. And part of the reason for that is because when you work out where is the problem, that can give you a very good idea of what type of problems exist in those locations of the nervous system. And we'll go through this in a bit more detail. I mentioned that there's, I'll just move this down. I mentioned that there's, when you ask the question, where is the problem? It could be a central problem or a peripheral problem. And if it's a central problem, well, it could be in the cerebral cortex or in the cerebellum or in the brain stem, or it could be a peripheral problem in the spinal cord or the anterior horn cells or the peripheral nerves or the neuromuscular junction or the muscle itself. And so you can divide the nervous system up into those different areas. And by using clinical signs, you can estimate where the problem is. And as I said, once you've addressed the question, where is the problem, then you can start to address the question, what is the problem? But a lot of people, they start off by trying to work out what the problem is without working out where the problem is. So let's try to always be working out where the problem is first. Now, I'm not sure whether you can see this slide very clearly, but I have put in the different levels of the nervous system. So the cerebral cortex, the cerebellum, the brain stem, the spinal cord, the anterior horn cells, the peripheral nerves, the neuromuscular junction, and the muscles. Remember, these are the levels that I said when you ask the question, where is the problem? And then on the top are the different types of problems that you can get there. So whether the patient has normal higher functions, whether they are alert and interactive or not, what their tone is, what their power is, what their reflexes are, what their sensation is, and what their oops, what's that say? Their function, and what possible diagnoses are there. And it's possible by going through each of these as you do the neurological examination that you can work out what type of diagnosis is likely. And we'll go through some examples. I think it's useful to think about paediatric neurology in terms of a few common presenting features. And so often we are faced with the hypotonic or the floppy infant, or we might be faced with a child who's got new onset of difficulty walking. They were walking okay and then they stopped walking. Or we might be faced with a child who's got a hemiplegia, or the child with delayed walking. That is, the child never walked up until the age of 2 or 3, and a parent brings their child along with a problem with their walking. Or it might be a movement disorder, for example, chorioathetosis. And so there are more symptom-based problems that children come along with. But I just wanted to go through a few of those today. The hypotonic infant, a child with a new onset of difficulty walking, that is, as in they could walk, but now they can't walk. A hemiplegia, sudden onset of hemiplegia. A child with delayed walking who hasn't walked up until an age in which they should, and then a child with a movement disorder. Let's go through some of those and try to identify how, by asking that question, where is the problem, followed by what is the problem, we can arrive at a neurological diagnosis. Well, first of all, the hypotonic infant. Well, we see many infants who are more floppy than they should be. And that could be that they've got an acute onset of floppiness, or they've had hypotonia or lack of tone or floppiness from the time of birth. And when we see a child like that, it's really important that we assess their level of alertness. Whether they're alert or not alert can tell you a lot about whether or not the child has a central problem or a peripheral problem. We should assess their posture, and many hypotonic infants will lie with their limbs abducted in a sort of frog-like posture. They may have their arms lying beside their body, their trunk in a flaccid way, and they may have a lack of anti-gravity movement. Like all babies, even from soon after birth, should have some anti-gravity movement, unless they're very preterm babies. So a lack of anti-gravity movement, they can't lift their arms or their hands off the bed, is a sign of hypotonia. Then there's a number of tests we can do, just examination tests. We can do what's called the traction test, what's called vertical suspension, and horizontal suspension. These are just simple ways of holding a baby that can tell you something about their level of tone and their flop, and whether or not the problem is central or peripheral. The traction test is simply you lie the baby down and then pull the baby up. And most newborn babies should feel the infant pulling against their the traction that you're applying on their arms. They should have flexion of all their limbs at their elbow and their knee and their ankle. They should have some tone, and they should be, sort of resisting, but also helping you pull them up. The normal infant lifts their head from a flat surface immediately. When you start pulling them up, their head doesn't lag, so their head should lift up first. They only have head lag up until the age of about 2 months, and beyond that, they should be able to lift their head up as you pull them up. And when you lift them up with this traction test, their head should be in parallel with the lift of their body. When you're lifting their body, their head should come up as well. That's the traction test, and it can tell you something about where their hypotonia is, whether it's central or peripheral. There are some clues to central hypotonia, and one of them is the way babies can hold their hands. Most babies don't hold their hands with their fist in their thumb inside their fingers. This is called the fisting of their hands. And if you see that, it's a sign of central hypotonia, that there's something wrong in the cerebral cortex or in the cerebellum that's leading for them to have that degree of hypotonia. That babies who've got a central hypotonia will have an altered conscious state. They won't be as alert as they should be. They will be they won't be able to engage like they should. So look to see if they're alert or not alert. Have a look at their hands. See if they've got scissoring of their legs in ventral suspension. So ventral suspension is you just hold them up under their arms, and just two things. You can feel whether or not their arms are floppy, as in their arms just go, their arms go up when you hold them under their armpits. That tells you that they've got truncal hypotonia. And the other thing you can see is whether they've got scissoring of their legs in vertical suspension. You should do their reflexes, and if they've got central hypotonia, their reflexes will be up. And sometimes they've got abnormalities of their other organs if they've got central hypotonia, and sometimes they've got microcephaly. But the main things are, look to see if they're alert or not alert, if they've got fisting of their hands, if they've got scissoring of their legs, if their tendon reflexes are increased, and if they've got microcephaly. All of those things point to a baby who's got central hypotonia. On the other hand, if they're really alert, if they're interactive and looking around, if their hands are in a normal position, if they don't have any scissoring of their legs, they're just hypotonic, and if they've got reduced reflexes and they've got a normal head circumference, then probably they've got a form of peripheral hypotonia. As I said, the clues to peripheral hypotonia, they're floppy, they're not stiff. They don't have that scissoring. They've got reduced tendon reflexes. They may have muscle atrophy if their peripheral nerves are affected or their muscles are affected. They may have fasciculation too, which is a flickering of their tongue. That's a particular feature in some types of peripheral hypotonia. Their conscious level is usually normal. They're usually alert, and they have generally no other abnormalities of their other organs. And so from working out whether or not the baby has central or peripheral hypotonia, you can then start to think about what types of illnesses the baby might have. So, for example, there are a number of conditions causing peripheral hypotonia in infants. Like we see babies a lot who've got hypokalemia. Their potassium is quite low, and usually that's from diarrhea. But hypokalemia, when you've got a potassium of 1.5, then you'll be very floppy, and that can be a cause of acute peripheral hypotonia. And usually those babies will, if they're dehydrated, you'll see clinical signs of that as well. In the first few weeks of life, sometimes babies have spinal cord trauma. That's rare, but following birth trauma, that can lead to a peripheral hypotonia with spinal cord involvement. Other babies that are floppy, babies with Down syndrome, they're hypotonic. There is a condition called spinal muscular atrophy that involves the anterior horn cells, or polio can lead to acute flaccid paralysis. There's another condition called botulism, infantile botulism. And then there's a few other conditions like Prader-Willi syndrome and other things. But I guess acute flaccid paralysis, hypokalemia, Down syndrome, and spinal muscular atrophy are the most common causes of peripheral hypotonia. And those babies are generally alert, but they have central hypotonia. They don't have scissoring. They don't have, the reflexes are down. They have all the signs of peripheral hypotonia. Botulism is an interesting disease that I think we probably see a bit more often than we recognize. We probably don't recognize it very much, but they're babies that in the first 2 to 6 weeks to 6 months of life can present with hypotonia and failure to thrive. And they have severe and progressive paralysis. And it's caused by Clostridium botulinum toxin, not tetani, not Clostridium tetani, but Clostridium botulinum. And it occurs quite commonly in babies who live in dusty environments, like where there's been agriculture or the construction industry is on. And they usually present with the hypotonia and failure to thrive and constipation. And they have ptosis, so their eyelids can't be elevated. They often have a weak cry. And the clue to it is their ptosis, and they have dilated pupils and often a very poor light reaction. Sometimes people think they've got a central problem, a brainstem problem. It's actually just the effect of the botulinum toxin on their pupillary muscles. I won't go into the treatment, but just in terms of just to think about infant botulism, when you see a baby who's got hypotonia, and they're the clinical features. All right, so we've talked about the hypotonic infant, especially babies that have got peripheral hypotonia, thinking about acute flaccid paralysis and botulism and spinal muscular atrophy and hypokalemia. I want to talk now about new onset of difficulty walking, because I think this is another common clinical scenario we're faced with. So this was I'm going to give a short case study here of a 12-year-old boy who had progressive weakness of his lower limbs over 2 days and back pain. And now he can only walk with assistance. Now he could have new onset of difficulty walking, could be something that's central or it's something that's peripheral. And it's our job to work out what it is. So on examination, this boy's conscious state was normal. His upper limbs were strong and he had normal sensation. In his lower limbs, though, his tone was increased. He couldn't elevate his legs above resistance, against resistance, so he had very weak anti-gravity movement. He could just shuffle his legs in the bed, but he couldn't elevate them above the bed. His knee jerks were markedly increased, and he had altered sensation in his thighs and his lower legs and in his feet. And he couldn't do any heel skin test or any tests of coordination. But his upper limbs were normal. He could do the finger nose test with his hands, and he had a palpable tender bladder. So from what I've described already, you should be thinking to yourself, well, where is the problem? And then what is the problem? And remember, I said, first of all, you ask, where is the problem? After, what is the problem? And again, you can tell from the examination features where the problem likely is. His conscious state's normal, so we're thinking that perhaps it's not a central problem, perhaps it's a peripheral problem. And if it's a peripheral problem, could it be in his spinal cord or his anterior horn cells or his peripheral nerves? Or again, if it's in the anterior horn cells or the peripheral nerves, like with acute flaccid paralysis, usually the patient will be flaccid. They won't have increased reflexes. They won't have increased tone. So we're thinking here a problem that's likely to be in the spinal cord, isn't it? It's not likely to be in the peripheral nerves because the tone would be down, the reflexes would be down, the they may or may not have altered sensation. Yeah, so this is a plain X-ray of this boy's chest and abdomen. It's really of his thoracolumbar spine, especially thoracic spine. Can anyone see anything on that X-ray? It's a little hard to perhaps see, but can you see anything that might give you a clue to what the problem is or where the problem is? It's a little hard to tell, but you see this line here. This is just his plain X-ray, and this is not his heart. This is too small to be his heart. It looks like there's something surrounding his mid-thoracic vertebral column, isn't it? And if you look on this X-ray, which is a bit more penetrated, you can see that one of the vertebral bodies seems to be collapsed, and there's a swelling surrounding his vertebral column. So I think we've identified most likely where the problem is and the type of problem that it is. It's likely to be a spinal cord problem with spinal cord compression. And that would go along with the clinical features I said, which is that the tone is increased in his lower limbs, but not in his upper limbs, that there's increased reflexes and altered sensation in his lower limbs, but again, his upper limbs are normal and he's alert. So again, asking the question, where is the problem, followed by what is the problem? Now, this boy had a paraspinal abscess. So you can see the soft tissue swelling, and he had a paraspinal abscess and vertebral body destruction. So like osteomyelitis of the vertebral body with a paraspinal abscess causing spinal cord compression. And so by working out exactly where the problem is, you can tailor your investigations to find out what the problem is. And so when you've got a spinal cord problem, this is just a line from that table I showed before. The conscious state will be normal. The tone is usually increased, but sometimes it can be decreased. The power will be reduced below the level of the lesion. The reflexes will generally be up, will be increased. Sometimes they can be decreased. Usually coordination is limited by the motor weakness below the level of the lesion. So if you've got a mid-thoracic lesion, then below that, you won't have any coordination. And you'll usually have altered sensation. It can be reduced sensation or just altered sensation like paresthesia below the level of the lesion. And the sorts of so this is where the problem is. And if you think about what the problem could be when you've got a spinal cord lesion, well, it could be a trauma, or it could be like in this boy, an abscess, a paraspinal abscess, or Pott's disease, or transverse myelitis, or a tumor. So they're the things when you're thinking about what is the problem, then you can arrive at those different diagnoses because you've worked out accurately where the problem is. And again, we didn't need a CT scan or an MRI scan to work this out. It was based on the clinical features and going through them to work out where the problem is, followed by the short list of differential diagnoses as to what the problem could be. Now, this is another example of a common neurological problem of hemiplegia. Now, it won't be, I think you know this, but when you've got a hemiplegia, then usually the problem is in the cerebral cortex on the contralateral side. It's a central problem, usually affecting the cerebral cortex on the contralateral side. Sometimes it can be a unilateral spinal cord problem, but usually it's a cerebral cortex problem. That's the most common thing. So when there's a hemiplegia, one side of the body is weak or immobile. Usually there's hypertonicity, but sometimes there's hypotonicity. Sometimes there's floppiness. There's usually hyperreflexia. There's usually upgoing a plantar reflex. And sometimes other higher functions like speech will be impaired, or there'll be visual neglect. And that gives you a clue that it's a central problem. And the effective, and it's an effect of a lesion on the contralateral cerebral cortex. So when you see it, if you see a child who's got hemiplegia, then it's useful to ask the question as to, is it acute or is it slowly progressive? If it's an acute onset hemiplegia, then when you're thinking about, well, what is the problem, then it could be the child's had a stroke, or they could have a hemorrhage, like a cerebral cortical hemorrhage, or it could be something like hemiplegic migraine or hemiplegic epilepsy, or you need to examine them to see if they've got heart disease with cerebral embolus, like they've had a stroke from heart disease, or it could be an infection like meningitis or a cerebral abscess, or a vasculitis like lupus, or if they've had cancer. Sometimes you can have complications of cancer with a stroke, or they might have a venous sinus thrombosis. So what is the problem in a hemiplegia? There are a number of different types of problems you can see in a child with a hemiplegia, but work out, if you can first, where is the problem, and then you can speculate based on the other clinical features, on their history and their other clinical examination, what is the problem? What type of stroke have they had, or is it a hemorrhagic stroke or a thrombotic stroke, or is it a stroke related to heart disease, or a stroke related to an infection like meningitis, or a stroke related to a connective tissue disorder like lupus? Or do they have something else that's transient, like a hemiplegic migraine? If their hemiplegia is chronic or slowly progressive, then you need to think whether they might have a brain tumor or a tuberculoma, or they might have cerebral palsy as a cause of hemiplegia. And so the history there gives you a very good understanding of what type of hemiplegia the child might have. So where is the problem first, followed by what could the problem be, or what is the problem? When you're considering a child who's got a hemiplegia, then certainly you should do take a full history and do an examination to look for fever or other signs of infection that might point to abscess or meningitis or tuberculosis. Look for whether the child's got a heart murmur or cardiomegaly on a chest x-ray, or clinically for evidence of congenital heart disease or rheumatic heart disease that might lead to a stroke. See if they've got a rash or something that might suggest a vasculitis, or if they've got other signs that might suggest tuberculosis or a hemorrhage, or if it's something that comes and goes, maybe they've got a hemiplegic migraine or hemiplegic epilepsy. That's less common, but it does occur. Or is it something that's been there since the time of birth, and that in which case they might have cerebral palsy? So the history and the examination tells you what is the problem, and your clinical features will tell you where the problem is, which side the problem is. Now, finally, or the second last clinical syndrome I wanted to go through, we've talked about the hypotonic infant. We've talked about the child with delayed, with a new onset of difficulty walking. And we've talked about the child with a hemiplegia, who also generally has difficulty walking. And now let's talk about the child with delayed walking. So that's a child that still doesn't walk even when they should. So this was a 2.5-year-old boy, and he still didn't walk. Now, 2.5 is too old to be starting to walk. Most children at 1 year and up to 18 months will start to walk. Boys are a little bit slower than girls, and usually all boys should be walking by 18 months. And if they're not walking by 2.5 years, then that's a problem. And usually these children will come to the attention of a paediatrician, or they'll bring their child to a doctor to work out why the child's not walking. This child could sit without support from about 1 year of age. So again, children should be able to sit without support from somewhere between 6 and 9 months of age. He could pull himself to stand. So if he pulled himself up on a chair or a bar or something like that, he was able to stand, but he couldn't stand independently, and he couldn't walk. On the other hand, he could do other things that seemed age appropriate. He was alert. He used his hands to play with toys. He could say several words and talk in short sentences. So at the age of 2.5, children should be able to do that. And he responded to sounds well, and he understood simple language conveyed to him by his parents. So the main problem was that he had delayed walking. Sometimes when you're faced with a problem of developmental delay, then you need to go back to assessing the child's overall development. And I think using a chart like this is quite helpful. I find it's good to pull out a chart like this. I'll send it around, but I think it's quite good to pull out a chart like this and then circle the things that the child can actually do and the things that they should be able to do for their age, but they can't do. And so this child was able to, in terms of head control and trunk control, he could move and hold his head easily in all directions. He could move his head around. He was okay like that. And he could sit well without support, but he sat quite late, didn't he? He's 2.5. He should be in this column here, and he should be able to walk on tiptoes and heels, but he couldn't do that. The best he could do was able to sit well without support. He couldn't twist or move. He couldn't do this activity, but he could sit well without support. He could pull himself to standing, but again, this is quite delayed for a child of 2.5 years of age. He could grasp with his thumb and forefinger. He had good fine motor control, and he looked around at things. He was quite alert, and he was able to understand simple language. So if you get a chart like this, you can sort of say, well, at a 2.5 year level, he's sort of up to date with fine motor skills. He's not too far behind with his hearing and his language, and his fine motor skills are almost there, almost up to date. But he's quite delayed in terms of his gross motor skills. And so this is like, you should think about gross motor skills, fine motor skills, vision and hearing and socialization. They're the domains of development. And if you use a chart like this, you can assess a child's gross motor skills, their fine motor skills, their vision, their hearing, and their socialization. Now, on examination of this boy, this is a picture of his legs. His conscious state, as I said, was normal. His tone was normal, but he was a bit floppy. His power was okay in his proximal muscles, his power in his proximal muscles was quite poor. His quadriceps were quite weak, but his calves were quite thick and swollen, and he had a mild scoliosis. And when he was trying to stand up, he couldn't even do this. But children with this problem, as they're older, when they stand up, they climb up their legs to stand up. They can't stand up without using their hands to stand up. This boy couldn't even stand up without support. He's being supported here, but this is how thick his calves were. So even though his muscle weakness was poor, his muscles seemed to be hypertrophied. They seemed to be thick. So when we're thinking about this child with delayed walking, well, where is the problem? Is it in his cerebral cortex? Well, he's alert and he's got normal fine motor skills. So it suggests that his cerebral cortex is okay. Given that he's got fine motor skills that are close to normal, his cerebellum is probably okay because that includes coordination. His brainstem's unlikely to be affected. He doesn't have any of the features of a brainstem problem. His spinal cord is probably going to be okay, again, because his tone is down and there's no level. There's no level at which below that he's weak. He's generally got proximal muscle weakness all over. His anterior horn cells, he doesn't have acute flaccid paralysis. He doesn't have muscle wasting. In fact, his muscles seem a bit hypertrophied, if anything. If it was a peripheral nerve problem or a neuromuscular junction problem, again, his reflexes would be down, but he might have muscle wasting. So it points really to a muscle problem. And again, by using the clinical features, the tone, power, reflexes, coordination, sensation of the neurological examination, you can work out in this child that's likely to be a muscle problem. And again, using a chart like this, it's not going to be a cerebral cortex problem. It's not going to be a cerebellar problem. It's really going to be down here somewhere because he's got normal higher functions. He's got reduced tone, reduced power, reduced sensation. And so it's likely to be one of these problems, but again, most likely to be a muscle problem because he's got muscular hypertrophy. So in terms of what the problem is, then it's going to be a myopathy or a muscular dystrophy. And these problems are seen in children all over the world. And there are certain types of muscular dystrophy or that are particularly occur in Papua New Guinea. So we think about Duchenne's muscular dystrophy. Well, there is that, which this boy had, but there's other types of muscular dystrophy that also occur sometimes in PNG. Duchenne's muscular dystrophy is the most common type. It's an X-linked disorder. It only occurs in boys, and they present with delayed walking, which is what I described. Sometimes they walk on their toes, and they have this problem called Gowler's sign, which I described before, that they, when they're old enough, usually not at the age of 2.5, but in around 4 or 5, when they can actually stand by themselves, they climb up their legs to get to reach a standing height. They have weak proximal muscles, so their thighs are weak and their shoulder is weak, but they have calf hypertrophy. Their muscles are thick, and that's mostly fat deposition in their muscles. They're not strong because they're thick. They're weak because it's fat deposition. By 15 years, most of these children are wheelchair bound, and they have a scoliosis because of muscle. Their muscles are weak, so their spine becomes curved. They develop also restrictive lung disease and pulmonary hypertension. Sometimes they respond to steroids, but not fully respond. The treatment is steroids and physiotherapy and mobilization. But in terms of today, I just wanted you to have an understanding of some of the muscle problems that can occur and lead to delayed walking. Now, of course, other problems can lead to delayed walking too, like cerebral palsy or like congenital hemiplegia or a spinal cord problem. They can all lead to delayed walking, but think also of a muscular dystrophy. Now, finally, I wanted to just talk briefly about a child who has a movement disorder. And we see movement disorders quite commonly, I think, in PNG, and they may relate to a lot of different underlying problems, which I'll just show you this picture of this child. You'll see another sign that I mentioned earlier, which was scissoring of his legs. This is a little boy who had, I'll just show you the video. So I'll show you again. Seeing a child who's got a movement disorder, you need to just look at the type of movements and see exactly what the child's doing and whether they're repetitive or not. Now, some people might look at it and say the child's having seizures, but in fact, it's not seizures. It's just a movement disorder. Of course, this child could also have epilepsy, but it's not. It doesn't have the type of the quality of movement like a child who's having seizures. It looks a bit different. You see the complex movement that he has of his hands. This is a movement disorder, a form of chorea or choreiform movements. You also see this other feature he has of the scissoring of his legs. Now, from just looking at this child, you can tell that this child's got a central problem. He looks alert, but he doesn't seem to be looking in a normal way. His eyes don't seem to be quite normal. And we know that what controls central movement are things like the cerebellum and also the basal ganglia, isn't it? And so this child has a basal ganglia problem. And I'll just show you again, you can then answer the question whether or not it's unilateral or bilateral. And probably his movement disorder is more marked on the left, but there's also some unusual movements on the right side as well. And so it's probably bilateral, but more prominently affecting the right cerebral cortex and maybe the right basal ganglia or the right cerebellum. If he had a cerebellar lesion, you might expect him to have nystagmus of the eyes, but he doesn't have that. He's just got a right-sided gaze. And so you might look at this child and then the question is it a sudden onset problem, or has it been there since birth, or just developed in the last few months? And that can give you a clue as to whether or not this child might have cerebral palsy, or he might have a tuberculoma, or he might have had a stroke. And remember, if this was a stroke, it'd have to be affecting both sides. If this was a tuberculoma, it'd have to be affecting both sides. this boy's got chorioathetoid cerebral palsy. That's what he's got, and it's a chronic problem for which, and interestingly, his intellect could be relatively normal. And so when you see a child who's got a movement disorder or a motor disorder like a hemiplegia, you should not always assume that their other development aspects, their intellect and other things might be abnormal. His intellect might be delayed or it might be normal. So today we've talked about neurological assessment of children based on common clinical features, common clinical problems. So we talked about the hypotonic infant. We've talked about the child with new onset of difficulty walking who has a spinal cord problem. We've talked about the child with delayed walking and with a hemiplegia and with a movement disorder. So that's what I wanted to share with you today, and just talk about the different clinical diagnoses that you can make based on an understanding of the neurological examination, and always asking first, where is the problem, followed by what is the problem. I'll send around these slides so you can have a look at the tables a bit more and practice the examination yourself. But that's all I want to say today, and I'll stop the recording and happy to answer any questions that you might have.